Hi, my name is Leah Showalter, and I'm an occupational therapist in home health. So when Jim asked home health occupational therapy to contribute to the Skills Day this year, I thought to myself, what would be an appropriate topic for all of us to learn and to gain skills related to the whole big picture of our practice scope, including inpatient, skilled, and home health. Obviously, the big new thing this year that we're dealing with is the COVID-19 pandemic. And I thought, it would be interesting to take a closer look at addressing interventions that would benefit our patients with this new normal. This has been quite a season, and over the last several months, I'm certain that we have all questioned our framework for providing interventions, and obviously have had to tweak according to precautions and prevention for the patient's health and our own. Since I'm a home health occupational therapist, I wanted to address how some of our framework has changed and possibly present some ideas that would make the carryover from hospitalization to skilled to home health to independence a more comprehensive process, addressing the new challenges the pandemic has brought to our treatment planning and interventions. Some of you know, but if you don't, I started out as a psychosocial occupational therapist. And when I was hired by Jim 20 years ago at Augusta Health, I was brought on to work with the occupational therapist on the psych unit. I don't even know if the psych unit is in the hospital anymore, is it? It is? Okay, cool. I had experience in private practice with a psychiatrist previously and worked on several other inpatient settings. Therefore, it's very difficult for me not to recognize the extreme importance of dealing with the psychosocial components presented by our patients. I would think that we could all agree that this year has certainly brought about a significant change and, quite frankly, the emotional well-being of the overall community along and with our patients, being members of that community. I wanted to provide some review, reminders, and possibly new techniques to manage the psychosocial occupational dysfunction that has been appearing to have an increase in our patients. I completed a CE International course on depression to prepare for this skills presentation, and the presenter, Dr. Blaine Smith, stated that depression affects 20% of the American population. Now, this was done before 2020, so you got to wonder what that number may be now. I've also been digging into my good old Gary Kilhoffner model of human occupation theory and application textbook for review to define correctly what I want to describe to y'all today. If you're seeing a patient and they are presenting to you with a question of depression, I wanted to introduce you, first of all, just this questionnaire. It's an assessment that it's allowed to be used with no regulated permission, and when our home health nurses open a patient, they perform the assessment. It's called the PHQ-9. It's a patient health questionnaire with 9 questions. The 9 questions are weighted, and you can use that to determine if a patient is appropriate to be addressed with their physician to possibly have them looked at for meds to address depression. Now, occupational therapists are always assessing the big picture. The components involved in this process, according to Kielhofner, include looking at first the patient's volition, which is their personal causation, which is a person's self-perception of adequacy and ability to meet their goals, values, and interests. Do y'all remember that? A long time ago. All right, so then we're looking at their habituation, okay, which includes the patient's roles and habits. Now, these are the big definitions of what we do every day, and it's actually kind of fun to look at the textbook and say, yeah, this is my language. This is what I practice every day. It's kind of fun to go back and look at that. Performance of activities of daily living and independent living skills are affected by the medical diagnosis along with the psychosocial dysfunction that's resulting in the person's current situation. So, an assessing occupational therapist should not only address the medical indicators, environmental accessibility, but also the psychosocial dysfunction more than ever in this season. We probably see this more in the home because we are walking into possible dysfunction that can't be denied or swept under the rug. We also do not have objects and environmental accessibility all set up as we do in the inpatient setting. It's our job to assess this. The elements of environmental accessibility, task orientation, what needs to be accomplished that day, social groups, culture, and how to provide the interventions to address these deficits has been significantly altered with the need to be safe with COVID-19. In one case study, I had a patient who came from the hospital after dehydration because she refused to drink tap water and was too frightened to go to the store to purchase water. Of course, water was her drink of choice, so she just deleted this from her diet. Upon assessment, it was realized that because of COVID-19, she did not have her normal social supports. Previously, she would go to Hardee's every morning for breakfast and meet with her friends. So our usual goal of improving her endurance and getting her back to her social interaction in the community was impossible. Now the question is, how do we provide education to ensure the patient is still getting their needs for social interaction and role performance met with social distancing and, quite frankly, the fear of interaction with dealing with others in the community? Of course, we think FaceTime or Zoom, and this is a possibility with the patient's technology and if they're savvy enough. We could teach the patient and the caregiver this skill. This could be addressed under caregiver education for another goal, maybe medication management or phone skills. You would tie it into that and get that goal done when I say medication management. All right, you might have to, you're stretching a little bit. The patients that don't have smartphones, which is quite frankly most of them, I'm starting to insist that they engage in calling friends and family daily. I make a daily activity log to assist them with remembering and accountability for this leisure activity. I assign this to patients who live alone. However, patients that live with family also derive satisfaction from meeting this psychosocial goal. This may seem like common sense, but we don't do it. We don't make sure that it happens. And sometimes I just think it needs to be part of the daily routine and to meet that need that these folks aren't getting met. So encourage the patient to be a support and interact with humor, laughter, be a friend. Point out their ability to smile and enjoy interaction during your intervention and carry that over to their own personal interactions. Patients that have a built-in social daily activities such as living in an ALF, I strongly encourage their participation in as much activity as tolerable and safe. These folks, they miss going to church. And is there any way that they can plug in somehow socially with those friends, maybe not in that framework, but with their friend visiting with their mask on, etc., somehow to meet that need. Another case study included a patient of mine who had an infected knee replacement, and her goal for rehab was to go to Walmart. This was before the pandemic. As she progressed, which ended up being a length of time, we needed to address what it would take to go to Walmart. Addressing her fears of infection from COVID. This particular patient was younger and didn't have as many comorbidities to be concerned about. So I was able to educate her on the realities of the fact that she could protect herself wearing a mask, staying 6 feet apart, and washing her hands. I needed to do some cognitive therapy to address the ineffective thought patterns that were feeding into her anxieties about meeting her goal of shopping. In summary, I guess I was hoping to introduce the concept of new processes that we can be recognizing and addressing across all localities of our care. I believe occupational therapy can be significant in meeting our patients' needs with ways to promote good medical with psychosocial health in the new normal. I hope this presentation stirs up others, you guys, to start brainstorming and coming up with other existing and new interventions that might assist our patients on their path to full recovery.